the possibility to take your time more. Arturo is again working hard on this, and it's my pleasure to let you introduce all your friends and speakers, please.
Thank you very much, Eduardo. Good morning, good afternoon, good night, depending on the part of the world where you are. It's a great privilege for me to lead this webinar where distinguished retinal specialists from all over the world are participating.
¿Van a llevar a los gordos ahorita?
Additionally, I have the honor of leading it together with Dr. Tarek Hassan, Barbara Parolini, and Jorge Rocha from Brazil. Before starting, I want to thank the Pan American Association of Ophthalmology and the International Council of Ophthalmology for their hosting, and the Sociedad Argentina de Retina y Vítreo and the Sociedad Brasilera de Retina y Vítreo for their support. It's a great privilege for the Sociedad Panamericana de Retina y Vítreo to share this organization of this marathon with the Retina World Congress. And finally, I would like to thank the coordinators, Dr. Andrés Lasabe, Dr. Camila Chaliol, Dr. Nicolás Krim, and Dr. Mariana Ingolotti. They really did a great job. So my sincere congratulations for all of you. But before starting, the president of the Retina World Congress, Dr. Tarek Hassan, will welcome you. Tarek?
Thank you very much, Arturo and Eduardo, and all of you for asking the Retina World Congress to participate and be a co-organizer with you on this wonderful marathon. This is really a magical day full of talks by experts from around the world, but especially highlighting the Pan American, Latin American Society of Retina Specialists and really all of their outstanding work. And the Retina World Congress is proud to be part of this with you and to share in the spread of this type of educational material around the world. So we're very happy to be with you, and thank you both for inviting us to be with you.
It's really a great pleasure. Thanks, Tarek. So let's start with the first module. Camila Chaliol and Jorge Rocha are going to coordinate it.
Thank you very much, Arturo. Thanks to the director for this opportunity. Welcome for being here. We are going to start with the first topic, angio-OCT in AMD's diagnosis by Dr. Rosa Dols Marco from Spain. Rosa?
Thank you, Camila, and thank you, Arturo and Jorge, for inviting me and for the opportunity to speak about this amazing topic, that it's OCTA in AMD. So I'm lucky because I think OCTA has a lot of useful information that allows us to really analyze patients with AMD in a form non-invasively with a high-resolution 3D imaging. It also allows us to early detect neovascularization and also allows us to increase our diagnosis abilities in cases that are really challenging. And we are going to see some cases. So, of course, we can see different types of neovascularization, and that's one of the main uses of OCTA in cases with AMD. But we can differentiate also the type of neovascularization. In this case, we see that the neovascularization is below the RPE, so we are going to classify that as type 1 neovascularization. There are different forms and types, and the patterns that we can see on the en-face reconstruction of the OCT will differ, but we are still learning what does it mean. But always in type 1 neovascularization, the flow information will be below the RP. Also, we have some variations or types of this type 1 neovascularization that it's called now aneurysmal type 1 or PCV. And with OCT angiography, we can see that it's quite challenging to see the whole lesion. We're going to see the branching vascular network really nicely, but the aneurysmal dilations are less apparent. But we can use the en-face structural information to see these lesions. Also, we know that we have type 1 neovascularizations that are non-exudative, and we are going to recognize these lesions really nicely with OCT angiography. You can see that there is an elevation of the RPE, and we see flow signal in the vascular area of the OCT angiography. So it's really nice to avoid doing fluorescein angiography in these type of patients. And also, we can, of course, diagnose type 2 neovascularizations. Here, the flow signal is going to be above the RPE. And we can see different patterns also, as we saw in the type 1 neovascularization. We will see always the flow signal above the RPE. Sometimes we have mixed lesions. We have atrophy of the RPE, like in this case. So we have a type 1 and type 2 neovascularization, and we can detect both the signal in the BE scan, but also in the en-face reconstruction. And we see some cases where we see first at baseline a type 2 neovascularization that it's going to regress into a type 1 neovascularization with treatment. And this we published that also where we see some cases with conversion of type 1 into type 2 into type 1 neovascularization. And also, of course, we can see RAP lesions or type 3 neovascularization. It's more challenging to diagnose type 3 neovascularization with the en-face reconstruction of the OCT, and we have to really analyze all the BE scans in order to check and look for this column of flow signal in order to detect this type of lesions. Those are more examples where we can see this dilation in the deep vascular complex of the retina or the vascular layer, but always look at the BE scan and this column of flow signal in the BE scan. And sometimes we have more challenging cases. We can see this patient with soft drusen, and we see some fluid, subretinal fluid in the center of the macula. And I think OCTA is quite useful here to see that we don't see any signal in the vascular area, so no flow signal. Here is the BE scan, and we clearly see the elevation of the RPE and no flow signal within the drusen. But sometimes we see that these drusen grow and they become more apparent in the center, and also subretinal fluid appears. And we have to be careful with these patients because sometimes we can detect really small lesions, neovascular lesions, that we have to carefully check. And we can see the flow signal both in the BE scan, but also in the reconstruction on the en-face. There are more challenging cases where we see also soft drusen, some calcified drusen with atrophy already of the RPE. And we see that at baseline, in this case, we don't see any flow signal in the BE scan or the en-face reconstruction. But over time, this patient will grow with a type 3 neovascularization, like we see here, and also the column here in the BE scan. And this is a more apparent case with a huge drusenoid, where we also see association with a type 3 neovascularization. Some cases are also challenging because we see hyperreflective material below the retina, and sometimes we can misdiagnose acquired vitelliform lesions with type 2 neovascularization. But I think OCTA, it allows us to detect that there's no flow signal in this hyperreflective lesion. So it's no, there's no neovascularization here. It's just a vitelliform lesion associated with soft drusen and cuticular drusen. And some cases with acquired vitelliform lesion, they present with some parts of reabsorption of this vitelliform material, and we can see subretinal fluid, and it can be also challenging, but again, we don't see any flow signal within this area of hyperreflectivity below the retina, and no flow signal in the vascular layer. And also, there are other signs that can appear in cases with geographic atrophy, that it has been described as plateau, that this is a persistence of basal laminar deposits, in these cases of atrophy. And we can see these hyperreflectivities in the outer retina. And again, if we do an OCTA, we will see that there's no flow signal within these lesions. This is another example of plateau, where we see this hyperreflectivity and no signal in the vascular layer. And this is the last case. This is a really challenging case where we see areas of atrophy. The fellow eye of these women has a neovascularization, and this case developed with changes and cystic changes in the retina. And this could be misdiagnosed as type 3 neovascularization with more cysts appearing. But if we do an OCTA, we will see that we don't see this column of flow signal in this case. So this is a pseudo type 3 secondary to the presence of incomplete RP and outer retinal atrophy. So in conclusion, there are many things that we can do with OCT, but I have been focused only on the things that we can do in the clinic, not in the research community. But we can differentiate the different types of neovascularization, see if it's type 1, type 2, or type 3 lesions, and of course, diagnose the challenging cases that we associate with different hyperreflectivities and signs that are associated with these neovascular forms that we don't have to treat. So I think OCT angiography, it's a really useful tool for these all these challenging cases. Thank you so much for your attention.
Thank you very much, Rosa. Very interesting the presentation. I wanted to ask you a question. If there are validated OCTAs biomarker for wet AMD, what do you think?
Well, I think there are many, there's many information that we can analyze. There are many studies, and for example, Dr. Saraf, maybe he will talk about that. He has been analyzing a lot of parameters in the OCTA, but I think we still have to learn a lot. And I think with quantification, we will learn much more. But still, there are many limitations on the technique, and we have to be aware of these limitations. So we have to know what we are seeing and be careful with the conclusions we draw with the information of the OCT angiography.
Thank you very much. Let's move on to the other topic, which is OCT biomarkers in AMD by Dr. Francisco Rodriguez from Colombia.
Hi all.
Hello, Jorge.
Hi all. I'm very proud to announce Francisco Rodriguez. He's the chairman of ophthalmology in the University of Rosario, Bogota. And on top of that, he's a great friend and well known for everybody. And today he's gonna give a pleasure of us to speak 10 minutes about OCT biomarkers. I know that's not easy because we have so many information about biomarking OCT, but he can do that. All yours, my friend.
Thank you, Jorge, Camila, and good evening, and thank you very much for the organizing, for the invitation. Several biomarkers has been described for AMD for diagnosis, progression, and also for outcomes. Some general biomarkers are listed here. However, with the OCT, the drusenoid pigment epithelial detachment, the hyperreflective foci, subretinal hyperreflective material, and external limiting membrane and photoreceptor loss, and the outer retinal tubulation have received special attention in the last years. So let's review some of the cases that I've seen with some of these biomarkers. This is a 60-year-old female with a diagnosis of neovascular AMD in the right eye and intermediate AMD in the left eye. When we saw this patient, she was 20/25 plus 2 in her left eye. She was having a drusenal pigment epithelial detachment, subretinal drusenal deposits, and some type of drusen in his left eye. In the follow-up of this patient at week 16, she was still 20/25. However, the drusenal pigment epithelial detachment had increased in size, and it happened the same as at week 32 when you see the pigment epithelial detachment. The drusenal pigment epithelial detachment had increased in size, and it's also there is a presence of hyperreflective foci and in this eye. And later on, almost 2 years after the first visit, her vision was still 20/25. However, you see the drusenal pigment epithelial detachment had increased in size, along with the increase in the number of hyperreflective foci. So how do we follow up these patients? Do we have any information which patients are going to geographic atrophy or neovascular AMD? So far, we know that drusenal pigment epithelial detachment is defined as a yellow elevated mound with one or more large self-confluent indistinct drusen with a diameter of greater than 433 microns. From this data from the ARETS study, we know that this drusenal pigment epithelial detachment may progress to late AMD, mainly geographic atrophy. And also, with time, these patients may be at high risk of lose more than 15 letters at the end. So this is another patient, a male with a 66-year-old male with decreased visual acuity in the right eye due to atrophy. So he came for a second opinion regarding his left eye. He was 20/25 at that time. This is the images of the right eye showing the atrophy of the external retina. And these are the images of the left eye showing a drusenoid pigment epithelial detachment with the presence of some hyperreflective foci and some type of drusens such as cuticular drusen. This is the patient in 218 showing the drusenoid pigment epithelial detachment and the hyperreflective foci. And at this time, we don't know how to follow up this patient because we don't know if he's going to develop geographic atrophy or macular neovascularization. So this is 2 years later that the patient developed a flattening of this drusenal pigment epithelial detachment and an IORA, but the visual acuity is still 20/25. So what would we know about these RP changes and the drusen volume in drusenoid pigment epithelial detachment? So far, we know that the larger drusenoid pigment epithelial detachments demonstrated a faster rate of collapse, and also the RP structural alterations prior to this collapse of the pigment epithelial detachment include the intraretinal hyperreflective foci, IVLS, and also disruption of the RPE. These hyperreflective foci are small hyperreflective dots in the neurosensory retina. This reflectivity is equal or greater than the RPA band, and were first described by Koskas and Schumann in 2009. This female patient, a 60-year-old female patient, who came to visit us after she was referred by a colleague. She was 20/25 at that time. And you can see that the pigment epithelial detachment present with a hyperreflective foci. 11 months later, you see that the detachment is decreasing in size, and her vision is still the same. 14 months later, the almost flattened the pigment epithelial detachment, and her vision is still 20/25. However, almost 2 years later, she developed some subretinal and intraretinal fluid that require treatment with anti-angiogenics. So the biomarkers for AMD progression, the presence of baseline hyperreflective foci has significantly associated with the appearance of any geographic atrophy at year 2, independent of the presence of baseline geographic atrophy. And also hyperreflective foci in eyes with intermediate AMD correlates with the 1-year risk of progression to late AMD, and in particular with the development of atrophy. This is a 66-year-old male with a disciform scar in the left eye and intermediate AMD in the right eye. This picture shows that there is a presence of drusen in his right eye. And almost a year and a half later, there's an increased number of drusen and also the presence of hyperreflective foci and also a drusenoid pigment epithelial detachment. So this is a patient in 2016. How do we follow this patient? We ask him to come back later on for a follow-up, but he came back 3 months later because complaining of decreased visual acuity to the level of 20/80 and the presence of intraretinal and subretinal fluid, and also the presence of hyperreflective material and the disruption of the external limiting membrane and the ellipsoid zone and hyperreflective material. So far, we know that this hyperreflective foci represents a predictive biomarker for progression or conversion to neovascularization. There are some biomarkers described also for AMD regarding the visual prognosis. And those associated with poor visual prognostic include the high number of subretinal hyperreflective foci, poor initial visual acuity, and ellipsoid zone disruption. Also, the subretinal hyperreflective foci could be a good predictor of final photoreceptor integrity. This is another patient, a 66-year-old male that we were seeing before. His vision was 20/80, and this is the presence of hyperreflective material, the irregularity of the external limiting membrane and the ellipsoid zone, and also the presence of hyperreflective foci. So what happened with this patient? We treated with several injections of anti-VEGF, and this is the end of the story. The patient improved his vision to 20/50, but there is still disruption of the external limiting membrane and the ellipsoid zone, the presence of this hyperreflective, subretinal hyperreflective material. This subretinal hyperreflective material is located external to the retina and internal to the RPE, and is becoming an important morphological biomarker. The composition of this subretinal hyperreflective material is not well established. It's likely to be composed of fluid, fibrin, blood, scar, inflammatory components of and CNV, but this composition changes over time. However, there are some characteristics that are important to know about this subretinal hyperreflective material, such as the localization, because when it involves the fovea, the visual acuity is affected, such as in this patient. Also, the width and the height is important because the foveal center width to a greater extent than height had the greatest adverse effect on visual acuity, such as in this patient. And also the well-defined borders represent fibrotic tissue or mature neovascular complex associated with poor visual outcome, such as in this patient. And the reflectivity is good to know that the high reflectivity indicates a persistent subretinal hyperreflective material. Finally, ellipsoid zone integrity is important because this subretinal hyperreflective material may damage the overlying photoreceptors directly by a toxic effect. This is a 61-year-old female patient that came because she had a decreased visual acuity. She was treated with several injections of anti-VEGF without improving, and her vision was count fingers at that time. After a follow-up of 6 months, her vision and more treatment given at this institution, her vision improved to 2400. However, there was this hyperreflective material present along with the disruption of the ellipsoid zone and the external limiting membrane. A year later, her vision is still worse, and to the level of 20/80 to 800, and there is a disruption of the external limiting membrane and ellipsoid zone. And this is the final follow-up. The patient is still 2400, no improvement in visual acuity. There is a disruption of the external limiting membrane and ellipsoid zone. So we know that there is a significant association between the condition of the external limiting membrane and ellipsoid zone on OCT with visual function in neovascular AMD. Finally, the outer retinal tubulation that arises in cases of advanced disruption of the outer retina and its presence suggests a poor visual function, so it given as a prognostic value. Also, the outer retinal tubulation is composed primarily of cone and Mueller cells, and the histologic characteristics of this outer retinal tubulation are listed here. As a take-home message, I can leave you with the true pigment epithelial detachment is associated with RPE changes and are identified as an independent risk factor for the development of late AMD. Hyperreflective foci and with intermediate AMD correlates with the risk of progression to late AMD. The presence of hyperreflective foci are a hallmark of blood retinal barrier function. So retinal hyperreflective material characteristics of poor prognosis include well-defined borders, high reflectivity and width, And finally, the external limiting membrane disruption and the outer retina tubulation suggest poor visual function. Thank you very much.
Excellent, my friend. I would like to ask you one question. The hyperreflective foci is a very important biomarker. And do you happen to know what kind of cells or biological material is composed this reflective foci? Francisco?
I'm sorry. Yes,
could you hear
it seems to be RPE cells that are helping these that are composing this hyperreflective material. Hyperreflective foci, I'm sorry.
Yes, yes. It's composed mostly by RPE and some inflammatory cells, and they can predict the evolution of the macular degeneration. But very good. I have many questions for you, my friend, but I can't do because the time is so limited. Please, I think thank you very much, and Camila, go on and.
Thank you very much, Dr. Rodriguez. Next topic is multimodal imaging of non-neovascular AMD. It will be presented by Dr. David Saraf from the USA. He can share. Perfect. Welcome, Dr. Saraf.
There, everyone can see my screen?
Yes.
Okay.
Yes,
good.
perfectly. Thank you.
All right. Thank you very much. It's a pleasure to be here with all of you. It looks like we have a predominantly South American contingent, and I'm happy to be here and share this presentation with you. So I'm going to be talking about the multimodal imaging and non-neovascular AMD, my disclosures. We'll start out with the basic classification of AMD, non-neovascular AMD, and the different types of drusen that we can see with multimodal imaging. So this is the Beckman classification, which is, I think, considered the most popular and the gold standard way to grade macular degeneration. Drusen can be in different sizes. When the drusen are small, we consider this early macular degeneration. 63 to 125 microns. Large drusen are greater than 125 microns, and this constitutes the intermediate form of non-neovascular AMD. And of course, the late form is characterized by geographic atrophy and neovascularization. So let's see what these different drusen types look like. A large drusen used to be, we originally classified these as soft drusen. Typically, when they're large like this, they have a drusenoid pigment epithelial detachment on the OCTB scan, and they're hyperautofluorescent on this. Recently, we made drusen sometimes can be appreciated on color fundus photography, typically in the superior macular region. They have the characteristic reticular pattern on fundus autofluorescence, and they can either be in a ribbon or a dot-like pattern. And here you can see the ribbon pattern on both the fundus autofluorescence and on the OCTB scan. The dot-like pattern, the stage 3 form, are comprised of drusen, again, above the RPE that actually penetrate through the ellipsoid zone. And these lesions have a kind of conical appearance on the OCTB scan. And sometimes you can appreciate them on color fundus photography, but not always. On-FOS OCT can be very helpful to track and identify both the dot-like drusen, which you can see here, as well as the more ribbon form, which is this kind of undulation under the ellipsoid zone. And you can see in this patient tracked over 3 years, the on-FOS OCT was very helpful in identifying both patterns of drusen. This is a nice image that shows you the histopathological correlate of a reticular pseudodruse above the RPE versus a soft druse below the RPE, and the correlative near-infrared imaging, which can be very helpful in identifying pseudodrusen. There are, of course, other types of drusen that we should be familiar with. A mineralized drusen or calcified drusen have a very characteristic appearance on OCT with a cap of hyperreflectivity over a hypo-reflective core. And these appear refractile on color imaging and often are associated with RP atrophy and geographic atrophy. Both Rosa and Francisco gave beautiful talks and discussed drusenoid pigment epithelial detachments. These are indeed higher risk forms of the dry or non-neovascular form of AMD that are larger areas of soft drusen that pool on the fluorescein angiogram and are at very high risk of progressing to the late form of AMD with collapse and atrophy. And we'll talk more about that later on in the talk. Another example of a patient with a high-risk drusenoid PD with pigment, another high-risk color feature, as well as the thickening of the RP, the intraretinal foci that Francisco talked about, and the hypertransmission, very high risk for the development of atrophy. As you can see in this follow-up scan, the patient went on to GA. So GA on imaging it has been evolving. Of course, our traditional gold standard way of assessing geographic atrophy has been with en-face color imaging. This is a well-circumscribed area, 175 microns in diameter, where you have bearing of the choroidal vessels. But you have to be careful. There are other conditions that can cause GA. Here's a patient with GA but you can see a very characteristic pattern of flex with peripapillary sparing. This is, of course, a patient with Stargardt's disease. And GA with Stargardt's disease can have very patterns versus A. You can see with IC, there's the dark atrophy pattern versus the bright atrophy pattern with AMD. And on OCTA, you can see that in GA in Stargardt's, there's a complete loss of the choriocapillaris with preservation of the choriocapillaris in the pericentral region, whereas in AMD, the choriocapillaris is not completely lost. That's why you don't get the dark atrophy with ICGA, and you see a lot of flow deficit in the area around the GA, an indication that this is AMD and not Stargardt's. Frank Holtz, we all are aware, has characterized the different forms of geographic atrophy with fundus autofluorescence, and you can see the banded and trickling form are the greatest risk for progression. More recently, I think Rosa have used this term C-RORA and I-RORA, complete RPE and outer retinal atrophy, and incomplete RPE and outer retinal atrophy. These are terms that the CAM, our classification of atrophy group, developed so that we could develop OCT grades of atrophy, which provide a much more detailed, granular way to assess RPE atrophy. And complete RPE and outer retinal atrophy is considered a region of 250, a continuous region of 250 microns, where the RPE is lost and you have choroidal hypertransmission with overlying photoreceptor loss. And you can see all these patterns on this OCTB scan. So a continuous area of RPE loss and hypertransmission with overlying areas of photoreceptor loss, evidenced by the loss of the EZ, the ELM descent, and you can often see areas of OPL subsidence, which we can show you as well. I-RORA is an earlier pattern of atrophy that we see, if you will, a nascent pattern of atrophy where you don't fulfill the 250 microns criteria. So you can see areas of hypertransmission, RPE loss, and even overlying photoreceptor loss, but the width does not subscribe to the 250 micron standard. So this is considered an earlier form of atrophy on the OCT. And of course, you can have outer retinal atrophy typically associated with pseudodrusen, where the RPE is intact, but just the outer retina is lost. And this is referred to as C-ORA or I-ORA, which we still need to formally define. We've talked about the biomarkers of atrophy, and those include hyperreflective foci, and sometimes these can assume a plume-like or feather-like appearance, and these are high-risk factors for collapse. And you can see this drusenoid PED that went on to I-RORA and then C-RORA over several years' time. We also can use on-phos imaging to identify geographic atrophy, and you can see in these panels developed from the area of neovascularization and growth to the preservation, recapitulation of the choriocapillaris, what that was originally described by Grosvenor, Klaus, and Green. Areas of atrophy seem to develop away from the areas of neovascularization. And on-phos OCT can be an especially effective tool to document progression of geographic atrophy, as you can see in this panel. I'm going to finish by talking about one last topic, and that's fluid in AMD. Rosa discussed degenerative cysts that can be associated with atrophic AMD, and you can see in this particular time-lapse video the development of a pseudocyst over the area of atrophy, and it's important to be aware that fluid can complicate the non-neovascular form of AMD. Against high atrophy that Francisco described, and then the development of fluid over the area of atrophy. We've also more recently looked at subretinal fluid in atrophy in this multinational cohort, and it's not unusual to see fluid over the area of drusenoid PED, and Rosa very nicely showed the importance of OCTA in excluding neovascularization in these different forms of fluid that can drape or develop at the apex of a drusenoid PED. And this fluid, along with the intraretinal foci, the hyporeflective cores, and the thickening of the RPE can be, as you can see here with these arrows, can be signs of impending collapse and atrophy, additional important biomarkers for the development of the late form of AMD. So that's a whirlwind tour of all the multimodal imaging signs of the non-neovascular form of AMD. Thanks very much for your attention.
Thank you very much, Dr. Saraf. I want to ask you a question.
Sure.
In your experience, do you think that aura may be a predictor for development of GA or multifocal lesions?
Yes, definitely. I think that we're still in the process of looking at these earlier forms of atrophy. We actually just completed a study looking at the natural history of iRORA to C-RORA. And in fact, in our cases, and we were able to use tracked OCT to identify and then track those cases over 2 years. And almost 100% of the cases of iRORA progressed to C-RORA, I should say iRORA, progressed to C-RORA within 2 years. So iRORA seems to be a very high risk factor for the development of more advanced grades, specifically C-RORA. And in fact, this may be used as a target for clinical trials and for reading centers in the future.
Thank you very much. Very interesting. Well, next presentation is about pachychoroid spectrum disease versus AMD by Dr. Joaquín Bafalui from Argentina.
Okay. Can you see my screen?
Yes.
But
perfectly.
Now?
No, right now, no.
Again. Excuse me. Here we are?
Yes.
Okay. Good afternoon to all of you. It is a great honor for me to participate in this important meeting. I want to say thanks for the Pan-American Society of Retina and Vitrio, Retina World Congress Organization, Pan-American Association, and Brazilian and Argentinian Retina and Vitrio Societies. The topic of my talk is pachychoroid spectrum disease versus age-related macular degeneration. These are my disclosures. Many times it is very difficult to differentiate between pachychoroidal disease and AMD. Furthermore, it is often difficult to differentiate between the same pachychoroid entities since the signs can overlap between them. Fortunately, in the last times, we can get access to new technologies that let's see the different layers of the choroids and measures. With this technology, we can see the innermost portion, the choriocapillaris, the middle layer is called settle layer, and the external thicker layer is the Haller's layer, consisting of large outer oval vascular patterns. Also, with the arrival of OCTA, we can see the different layers and paths. Thanks to this way of approaching, we can see the layer differently in their different vascular levels. As regards choroid thickness, these are the main features in normal people. In some juvenile diseases as posterior uveitis, we can see transiently increased choroidal thickness. While the thick choroid is frequently seen, choroidal thickness per se is not the most important criterion for defining this phenotype. Pachychoroid refers to dilation of the outer choroidal vessels called pachyvessels with attenuation of overlying choriocapillaris and settled layers. Some common features to the pachychoroid disease called pachychoroid phenotypes as useful to differentiate them from AMD. They are diffuse or focal increase in choroidal thickness, reduced tessellation in areas of choroidal thickening, dilated outer choroidal vessels called pachyvessels in Haller's layer, attenuation of the choriocapillaris overlying pachyvessels, hyperpermeability on ICG angiography, and presence of pachytrusion. At the moment, these are the diseases that belong to the pachychoroid disease spectrum. Frequently, one eye may present with signs characteristic of one group, while the fellow eye may exhibit signs from a different group. In addition, signs from more than one group may occur in the same eye simultaneously. Pachychoroid pigmentary epitheliopathy. These are very nice images from Dr. Friend, one of the most important colleagues in the macular disease study. Fundus examination often shows an orange reddish appearance and absence of normal tessellation, RPE alterations that might be confused with other diseases. Fundus autofluorescence shows areas of granular hypoautofluorescence and mixed stipple hyper and hypoautofluorescence. Signs of previous subretinal fluid, such as gravitational tracts, are never seen in PPE. OCT imaging shows numerous small elevations of the RPE. We can also see large choroidal vessels in the Haller's layer. PPE never presents subretinal fluid and may represent a form fruit of CSC. ICG angiogram reveals choroidal hyperpermeability. Focal choroidal excavation shows the same common changes like the other entities. Patients tend to be asymptomatic. There are two types. In the conforming type, the photoreceptor tips are not separated from the underlying RPE, whereas in the non-conforming type, a hyperreflective space can be observed between the photoreceptor tips and RPE. Pachychoroid peripapillary syndrome generally presents the same changes as the others, but in the nasal zone of the macular area and in the peripapillary sector. Central serous chorioretinopathy is a common disorder with serous retinal detachment, with or without serous PE detachment. The most common type is acute CST. The change observed in acute CST usually do not rise diagnostic doubts and are quite typical. OCT is an essential tool in the evaluation of both acute and chronic CST. When SRF persists, elongated photoreceptor outer segments and loss of ellipsoid and interdigitation zones are often observed with HD OCT, and sometimes together with subretinal fibrin, intraretinal lipid deposition, and subretinal yellowish dots in the fundus ophthalmoscopy. In chronic CSC, the retinal detachment are usually shallow and broad, with attenuation of outer retinal layers. Intraretinal fluid, sometimes referred to as cystoid macular degeneration. The findings often extend inferiorly in the form of a descending tract, most readily visualized with fundus autofluorescence. The most important difference between acute and chronic CSC is the presence of the choroidal neovascularization. Sometimes, in the setting of the CSC, the detection of CNV may be problematic due to the overlapping findings present in both CSC and the suspected CNV. For this French author, the presence of hyperreflective flat irregular PE detachment was associated to non-vascular detachment, no presence of CNV, whereas the hyperreflective flat irregular PE detachment, as we see in this case, was associated with choroidal neovascularization. In the multimodal imaging, we can see the typical features in late phase of the fluorescent angiography and hyperfluorescent plaque in the late phase of the ICG angiography. The OCT angiography shows type 1 CNV with a large trunk, peripheral anastomosis, and some areas of capillary sprouting. The next entity is the pachychoroid neovasculopathy, eyes with epitheliopathy, focal excavation, and CSC may develop type 1 neovascularization. This neovascularization is always type 1. These are its features. This is another case from Dr. Friend, where we can see the double layer sign. Besides that, in the right eye, the patient presents minimal subretinal fluid. The ICG angiogram shows increased impermeability in latest times. The OCT angiography shows the neovascularization as we suspected, but in the fellow eye, the OCT angiography lets us see neovascularization as well. In this case, it is a quiescent neovascularization without activity. Increased choroidal thickness, absent of minimal subtrusion, reduced fundus tessellation, and younger age are among the key features which differentiate pachychoroid neovasculopathy from neovascular AMD. The last entity is polypoidal choroidal vasculopathy, which is a variant of type 1 neovascularization. Several hallmarks of AMD, including drusen, pigmented changes, atrophy, and disciform scar formation, are relatively uncommon in PCV. In fact, the lesions aren't polyps, but aneurysms aren't in choroidal space because they are found between RPE and Bruch's membrane, and it isn't a vasculopathy, but neovasculopathy. Based on the presentation, PCV can be classified into quiescent, exudative, or hemorrhagic subtypes. PCV has been reported to have a higher incidence of serous retinal detachment and recurrent serous or hemorrhage PE detachment than eyes with typical neovascular AMD. Most investigators base the diagnosis of PCV on ICG angiography, findings that demonstrate the presence of polypoidal dilations with or without a branching vascular network, BVN. In the absence of ICGA, distinction between PCV and typical AMD remains challenging. On ICG angiography, there are two different subtypes of PCV. Type 1 shows the branching vascular networks, whereas the type 2 shows only polypoidal lesions. OCT is able to visualize many important changes. The PE detachment can be presented in different ways. The sharp PED has been called thumb-like polyps of PED peaks. Also, we can see the BVN, which can be suspected as a double layer sign. In PCV, OCTA has been reported to detect BVN as a hyperflow lesion. However, as Rosa said before, it only has a sensitivity of 40.5% for polyps. Therefore, with the present technology, OCTA is enabled to replace ICG angiography in the assessment of PCV. Anyway, sometimes the OCTA can help us, as this case from Dr. Friend again, where we can see the specific changes with this new method as well. You can see the changes in OCT and in the OCTA. Looking to the future, we need to improve the understanding of the challenges to face, switch from the non-neovascular disease to the neovascular variants, genetic and environment factors, the role of the venous congestion in physiopathology, imaging studies of flow direction and velocity, improve quantification of choric capillary thickness and blood flow, improve the access for the whole population to IgG and PDT until there are diagnosis methods and more effective treatments. Well, okay, thank you.
Thank you very
Well
much,
done.
Joaquin.
Well done, Joaquin. Great talk. I'd like to ask you, how do you manage this condition nowadays?
Yes, this question, we didn't have enough time to discuss treatment. This question has a different answer in each country, you know. For us who are living in Latin America, it is difficult to have access to IgG and PDT. Sometimes they are important to make an accurate diagnosis and a correct treatment, but we must do the best we can. We have fluorescein angiography, we have OCT, autofluorescence, we have OCTA, and we have access to anti-VEGF drugs, steroids, and laser photocoagulation for extrafoveal lesions. Many cases without exudation don't need treatment, and the others must be evaluated one by one individually.
Thank you.
Thank you.
You're welcome.
Well, lastly, we are going to introduce next topic, wet AMD management with multimodal imaging by Dr. Arnaldo Bordom from Brazil.
Arnaldo, can you hear us?
Yes, yes. Can you hear me?
Yes.
Good. Yes, yes.
All right. So it's an honor and a pleasure to be here with everybody, many of my friends, and it's a true honor to present the wet AMD management with the multimodal imaging. Can you see my screen?
Yes, but not in the play mode.
How about now?
Now it's perfect.
Perfect.
All right. Okay. So the previous speakers, they taught us about the images and how to identify many features on different protocols, different exams, like ICG, like OCT, OCTA. So here, I will present a little bit of more practical way with the clinical cases. So we have a lot of pots of potions, magic potions, to deal with. Are you still hearing me? So we can do either on research or clinical practice. In this talk, I'm going to talk only about in clinical practice. So among those pots from our potions, we have the best acuity, visual acuity, the colors fundus, fluorescein, OCT and OCTA, and autofluorescence. It's less used the ICG and not so often the microperimetry, contrast sensitivity, and multifocal ERG. So all of them we can use, not all together, but in many cases, several of these tests to address AMD. So let's start with the case one. This is a 63-year-old white female with decreased visual acuity on left eye for 4 months, no ocular history before, and just systemic high blood pressure. So this is the right eye, the panoramic colors, and the left eye when we can see some exudation. And I'm going to show you with enlargement of this color photo. And this is the autofluorescence, which is a very helpful technique that we can address in different cases. And the other eye as well, the autofluorescence. So the multimodal starts with the fluorescein angiography, when we can see a late leakage in that part of the lesion when there was a lot of exudates. But there was suspicions about this case. And here's the OCT, and we can see the retinal detachment, the fluid under the retina with a hyper-reflective lesion, and also a finger-like type of RPE detachment on the bottom of the screen. And you can appreciate this even better with this image. And we see the hyper-reflective under the retina and the RPE with the finger style. And again, here on the bottom of the screen, can you see the arrow, the mouse moving here? And we can see this lesion here. So what it did in this case was to perform an ICG. And though the ICG showed there was some polyps in this patient. So 3 months after treatment, and in this patient, I used the PDT and plus anti-VEGF to treat this left eye. And there was a reduction in the exudation. There was no more hemorrhage. And you can see there was less of leakage on the lesion on FL. And when you look about the OCT 3 months after, there's a flattening of the fluid, the subretinal fluid, as well as the retinal pigmented epithelial detachment that was seen before. This is still an ongoing patient. The patient keep improving vision and the images. As we can all see here, we're doing multimodal images to address this patient. Case 2. This is a different one. This is a 76 white female with decreased vision on the left eye for 1 month, with a high blood pressure, and she had a history of anaphylactic reaction when she performed endovenous contrast doing a CT scan, and she didn't want to have any kind of dye inject in her body. So the vision was 20/400 and 20/60. There was a mild cataract, and I'll show you the left eye fundus here. And the OCT, and pay attention to the arrow, as was shown before by the previous speakers, that we can see above the RPE and above this hyper-reflective that calls the attention to be a neovascularization type 3. And again, on the ANFAS and the B scan showing together. And I'm going to show you the movie because that's one feature of the OCTA that I think is very useful to highlight some lesions that we see among the layers on OCTA. On the left, you can see here, I'm going to stop the video a little bit. Pay attention to this yellow part that is showing, and it's going to highlight and get very thick on the left. On the right eye, the patient was treated with aflibercept, and look, 24 hours after the injection, look how this yellow part became very thinner comparing to the previous, to the treatment on the baseline. So I believe also multimodal approach is very helpful for cases that mimic AMD. And I'm going to show you another case here. This is a white female, 71 years old, with a metamorphosis on left eye for 5 months. Hypertension only and no ocular history before. Visual acuity was 20/20 and 20/40. IOP normal and no findings on the anterior segments. And here we see the right eye and now the left eye. First of all, when we see a patient, even if the patient is older, it doesn't mean that the patient has AMD. So we have to be very suspicious of all the disease can mimic AMD. And so we do the approach as to rule out AMD, of course, and other disease. So here in more detail, the macular area of the left eye, where the patient complains about the metamorphosis. The fundus autofluorescence on the right eye showed us some hyper and hypofluorescence around the fovea. And here, again, the hyper and the hypofluorescence within the macula. The patient brought some tests from the previous doctor, and the fluorescein 4 months before initial presentation to me. There was just a staining on the right eye, and you can see a sort of a leakage on the temporal side of this image on the macula. And the OCT as well, 4 months before, there was a detachment that we can see here of the neurosensorial retina on the left eye. And the right eye was perfect normal, or almost perfect. So we perform an ICG here, and on the ICG, we could rule out such conditions as PCV. And this is the other eye here, and again. And the OCT at presentation was a different scenario. There was a subretinal fluid sub-RPE. There are some hyper-reflective foci, and we can see another hyper-reflective material over on the top. And this patient was treated initially with anti-VEGF, and 3 months after 3 injections, there was a collapsing of all the fluid, and we can see a very hyper-reflective material here. And this is the color fundus and the OCT of the last follow-up, which was really recent. So to make a long history short, here's the right eye from 2017 up to now, and we can see not much of changes in the right eye. And on the left eye, this is the fundus autofluorescence and the color fundus. And also, we cannot see a lot of changes in the colors. And the patient was treating according to the year, as you can see on the bottom of the screen. So I would like to thank you, everyone, for sharing your knowledge and allowing me to pass a little bit what we can do in a clinical basis with the multimodal images for all these patients. Thank you again.
Thank you very much, Arnaldo. Excellent presentation. I wanted to ask you a question. Which are the most important imaging tools when you have to take treatment decisions for you in your daily practice?
Yeah, depends on the case. I think, first of all, we have a lot of tools. We have OCTA, we have ICG, we have FA, and you have to think about the case. I think the most important tool is the doctor's brain. So you have to think about the case and have very suspicious what case you are dealing with. So if you have a suspicion of PCV, in my opinion, and it was also beautiful shown for the previous speaker, Joaquin, that ICG is still the gold standard, all right? But in my clinical practice, I usually use the fundus, colors fundus, or I examine the patient. I use the FA, especially in the naive patients. I use ICG when I have suspicions of different disease or PCV. And I use autofluorescence a lot. I think it's a very helpful tool. I don't use a lot of OCTA. I use, but I see that in my clinical cases, in most of AMD cases, not so helpful. And I have only for research for now. In that case that I showed of RAP, it was very useful to show that. But you can see the type 3 neovascularization through FA, and also you could see as with ICG. So it's an adjunctive test. So that's what I use most in my clinical practice.
Thank you very much. Arturo?
So congratulations to all of the speakers for respect all the times. Excellent talks. And congratulations, Camila and Jorge, for the great job you did. So it was a pleasure to have all of you here. So let's move to the next module, that it will be macular edema and diabetic retinopathy. Dr. Lasabe is going to coordinate the next module with me. So Andres, let's start.
Good afternoon, everyone. Thank you, Arturo, for the invitation. Of course, it's a great honor for me to be part of this first meeting marathon organized by the Retina World Congress and the Retina Vitreous Pan-American Society. And as you said before, for this second part of the marathon, we have the honor of working together a select group of renowned worldwide experts in the field of retina, but with a special interest in diabetic macular edema and diabetic retinopathy. Our first speaker is Dr. Carolina Sardi from Medellin, Colombia. Carolina is part of the board of al-mamoori, and currently she's one of the younger, more relevant researchers in Latin America. And she's going to talk about multimodal imaging in diabetic macular edema and biomarkers. Thank you, Carolina, for joining us.
Thank you, Andres, for the presentation. And I'm very, very happy to be here today with all of you. And I'm going to talk about biomarkers in diabetic macular edema and diabetic retinopathy. And you know that we have several types of biomarkers. We have ocular biomarkers, circulating biomarkers, genetic biomarkers, and imaging biomarkers. But for the reason of time, we're just going to talk today about imaging biomarkers. And I want to introduce you two types of biomarkers. The first one are the progression biomarkers, and the second one are going to be the prediction biomarkers that I'm going to talk a little bit later. So about the progression biomarkers are those biomarkers that help us to predict if the patient is progressing in the severity of the diabetic retinopathy. And we have 4 of them. 3, we can find them in the OCTA, and 1, we can find it in the ultra-wide field fluorescein angiography. So the first one is the fast area enlargement, and it has been established that as the patient progresses in the severity of the diabetic retinopathy, also the area of the fast increases. So there is a positive correlation between fast area and DR severity. And this is so powerful that if you can see the area under the curve, we can use this area or this enlargement area to identify patients with diabetic retinopathy from those who has no diabetic retinopathy. The second biomarker is highly correlated with the previous one, is the acircularity. And the acircularity is a radio between the perimeter of the fast over the perimeter of a perfect circle. And also we can see that as the severity of the diabetic retinopathy progress, also does the circularity. So there is a positive correlation again between the fast acircularity and the severity of the diabetic retinopathy. You can see here how the median of those patients who are non-diabetics or the diabetics patient without diabetic retinopathy is almost the same. But as the diabetic retinopathy appears, the fast acircularity starts to progress. The third biomarker is the decrease in the percentage of the vascular density. So as the severity of the diabetic retinopathy progresses, the vascular density decreases. So this is an inverse correlation. And this happens in both in the superficial and in the deep capillary pressure. You can see how the vascular density goes down and the severity increases. So this inverse correlation is even stronger in the deep capillary plexus. So you have to keep in mind that if you have been following up a patient and you see that the percentage of the vascular density starts to decrease, mainly on the deep capillary plexus, you can be pretty sure this patient is progressing. The last biomarker that we're going to find in the ultra-wide field fluorescein angiography or fundus photography is the predominantly peripheral lesions, or PPL. This was established by the group of the Joslin Diabetes Center. They follow up a cohort of 100 patients, and they define PPL as those eyes that have 50% or more lesion outside the ETDRS fields. What they define? They found that those eyes with PPL, the proportion of eyes that progresses to a more severe diabetic retinopathy was higher in the group that has PPL versus the group that has no PPL. So again, if you have a patient like this that has predominantly peripheral lesions, you can be pretty sure that this patient is going to progress with 3 times the risk to progress to a more severe diabetic retinopathy and has almost 5 times the risk to progress to PDR. So these are my biomarkers that tell us about progression. Now let's talk about the prediction biomarkers. And we know that we have several options to treat diabetic macular edema, but what I want you to know today is that the morphology on the B scan can help you to choose the right treatment. The first morphology is the sponge-like diffuse retinal thickening. This is the most common morphology that you're going to find on DME. These patients respond very well to any kind of treatment, to laser, to pharmacology, and it has been correlated with a higher concentration of VEGF in the aqueous humor. The second morphology is the cystoid macular edema. This we can find in almost 50% of patients. And in this patient, the laser treatment is ineffective. And in this patient, it has been correlated with a higher concentration of inflammatory biomarkers on the aqueous humor. The third morphology is a serious retinal detachment. In this patient, the laser again is ineffective, and it has been correlated with a higher concentration of interleukin 6. And finally, we have the tractional morphology. Sometimes we can find it associated to retinal detachment, and they do not respond to pharmacology or to laser. They require vitrectomy. And if you have trouble trying to identify the traction, I think it's very useful to use the on-fast OCT to identify all the traction. But sometimes we have a patient that has everything combined, and it has been correlated with a higher concentration of VEGF and interleukin 6. So you have to use everything that you have probably. So remember that we have 4 types of morphology. The first one responds very well to any kind of treatment if it's isolated. The second and the third one are you can treat it with pharmacological therapy, and the last one you're going to need vitrectomy, and sometimes you have to associate it with pharmacological treatment. Another biomarker that is going to help you to choose the treatment is the hyperreflective dots. You know, that bright spot, they are as bright as the RPE. When they combine together, we can see it clinically as heart exudates. And an increased number of hyperreflective dots have been identified a good responder to the steroids. So those are the biomarkers that are going to help you to do the treatment selection. Let's talk a little bit about those biomarkers that are going to help you to see what could be the outcome, the visual outcome in patient that has been treated. And they are 3. The first one is the outer retinal band's integrity. You know that external limiting membrane, the ellipsoson, and the RPE interdigitation, those bright lights you can see in the outer retina. And the other one is the drill, the disorganization of the retinal inner layer. The drill is that inability to define the limits between one layer or another. These 2 biomarkers, if we have disruption of the outer retinal band, or if we have drill, has been associated with poor visual acuity despite recovery of foveal thickness and contour. But the new biomarkers I want you to keep in mind is the parafoveal vascular density. This is an exploratory analysis, but very well done, just published last year, and they define 3 areas on the OCT, in the 3x3 OCT map. They define the fovea, the inner parafoveal ring, which is from 1 to 2 millimeters from the fovea, and the outer parafoveal ring, which is from 2 to 3 millimeters from the fovea. And what they found is that the patients that had a good vascular density in the inner parafoveal ring and the outer parafoveal ring, this was correlated to a visual gain, both in superficial and in deep capillary plexus. So in conclusion, and this is the image that you have to keep in mind, we have two kinds of biomarkers. The first one are very useful for early detection, and I think that we're going to use them certainly in the future to identify those patients with diabetic retinopathy. And the second one are very useful for optimize the resources and for managing patient expectation. So I think in a very short term, these biomarkers will be integrated with genetic, serological, and clinical biomarkers to create predictive models that we can use to anticipate with. Thank you very much.
Excellent, Caro. Perfectly on time. Thank you very much. I have a question for you. As you say, some studies demonstrate that those patients with poor visual response to anti-VEGF therapy had an alteration of the deep capillary plexus in the OCTA. So with this in mind, do you consider that the use of the OCT angiography in predicting visual prognosis is necessary for all these patients, at least before starting treatment?
Yeah, I think it's a very difficult question because sometimes, because of the difference between the machines, we can have some artifacts that can be explained because of the great thickness in the retina. So keeping that in mind, I think that you can have an approximation when you start the treatment, but you have to know that probably in the evolution of the patient that can change.
Okay, and a brief question more is, what is the current role of the central macular thickness as a prognostic biomarker of visual acuity in this patient today?
Today, we are not using macular thickness anymore as a biomarker. I think that with the equipment that we have today, we have so great resolution that help us to see much more. And it's not that important. We use the macular thickness, because it's the main outcome we have in all the clinical trials, and it's very useful to explain to the patient, but it's not a biomarker that we take into account anymore.
Okay, perfect. Thank you very much. So biomarkers are not only important in prognosis factors, but also how to make the patients understand the severity of the problem and not generate false expectations. So now we have to indicate the treatment. And nobody better than Dr. Litibu to explain to us the current therapeutic strategies in diabetic macular edema. Lite?
Good afternoon. Thank you, Andres, Arturo, Tarek. So I'm going to be talking about diabetic macular edema, the current therapeutic strategies. These are my disclosures. And when I see a patient with DME, part of my workup involves getting an SD-OCT. I think Carolina mentioned it very nicely in her talk. Things that I specifically want to look at are whether or not the patient has some vitreomacular traction, an ERM, or even drill. And also I like to get a fluorescein because, as Carolina mentioned, it helps us to define areas of capillary non-perfusion in the periphery, and also can help us detect some NV that might escape our clinical assessment. We usually use the OCT in terms of deciding treatment, but you should be aware that, as Carolina mentioned, that the central macular thickness is not really a good surrogate for visual acuity. As you can see from this chart, you can have here paradoxical changes where patients with a thick macula have actually a good visual acuity. And in contrast, you can also have patients with a thinner macula with a really bad visual acuity. So here the correlation is only 0.44. So we do use the OCT to guide treatment, but keep in mind that it is not perfect, and we also need the visual acuity for that because patient's care is the visual acuity. With regards to ultra-wide field fluorescein, Carolina already mentioned that it is important in terms of grading because with ultra-wide field fluorescein, we can have more severe grading in up to 10% of eyes, and about a third of pathology are outside the 7 standard fields. Also, the presence and increasing extent of peripheral lesions are associated with increased risk of diabetic retinopathy progression, independent of the baseline diabetic retinopathy severity and hemoglobin A1C levels. Once we get all that information,
muy buena. Bueno, pero volvés a cobrar ahora, loca. Te tenés que comprar una campera abrigada, Flavia.
Your voice is changing.
Microphone, Lite. You have to turn on.
we get all that information, we can decide on the treatment choice. And for diabetic macular edema, we have several tools. But currently, I believe that the treatment of choice is anti-VEGF. So anti-VEGF, the things that we want to look at in deciding which anti-VEGF we want to use, depending on the circumstances, will be based on visual acuity following the protocol T results from the DCR-NET. Another point is also the chronicity, and a key time would be around 18 months, although this is not really set in stone. And remember that when we're going to use anti-VEGF, we should be prepared to give a heavy loading dose. And in my personal opinion, I think the patients should receive at least 6 monthly consecutive injections. So here we have the results of protocol T, and you can see the results stratify according to the baseline visual acuity. Those that have an initial baseline acuity better than 20/40, it doesn't really matter which anti-VEGF you decide to use. However, in those with a worse visual acuity, the use of aflibercept seems to be more beneficial than either Lucentis or Avastin. However, look at the gains. Even with Avastin, they're pretty good. So in Latin America, many times these decisions are made financially. So even if you choose Avastin, you can still get pretty good results. Once we get once we choose what treatment we're going to do, if the patient is a good responder, then we continue with an anti-VEGF following the DCR-NET protocol, and we stop once the patient achieves a 20/20 visual acuity with a normal OCT, or if the visual acuity remains stable and the OCT remains stable for 2 consecutive visits, and we resume if there is any worsening. So there has been a lot of talk about switching, and it has to do with the fact that even with 6 consecutive monthly injections, you can see here in protocol T that up to a third of patients with aflibercept had persistent macular edema, 40% of patients with Lucentis, and 2/3 of patients with Avastin had persistent macular edema. So the question is, what happens with these patients if you continue the DHC protocol over 2 years? So you can see here that if you continue with this protocol, around 44% of the original 32% will end up with persistent macular edema. So that comes about to perhaps like around a 15% of patients that didn't respond initially, and they will remain with macular edema at the end of treatment. With Avastin, it's even more. We're talking about maybe around 40% of patients. But is the persistent macular edema detrimental or not? And you can see here that even in those eyes that had chronic persistent DME, after 2 years, very few eyes lost visual acuity. Obviously, the eyes that gained more vision were those that did not have any chronic persistent DME. So when we look at this, it really depends on the patient's baseline visual acuity. So even though I mentioned that at 6 months, patients should be receiving 6 consecutive monthly injections, we should also look at how chronic patients have had the problem. So for instance, in this study, the RESTORE study, you can see that these are the active ranibizumab arms that were receiving monthly ranibizumab. And this is the sham arm that after 12 months, they were allowed to receive the ranibizumab, and they slowly caught on with the visual gains of the initial ranibizumab arms. This didn't happen in the rise and ride because the point where these eyes were able to receive the ranibizumab was after 2 years of treatment. So perhaps after 2 years, somewhere in between 12 and 24 months would be sort of like a cutoff point where patients will still respond to the anti-VEGF. The question becomes whether to switch or not. And when we look at the literature, you have to be a little bit cautious because most switching studies lack a control group for comparison. And you have to be aware of confounding factors such as the regression to the mean. So if I decide to switch, if I started with bevacizumab or Lucentis, then I decide to switch to aflibercept. And if I've started with aflibercept, then I decide to go the Ozurdex route. In terms of steroids, there are no head-to-head randomized clinical trials comparing steroids to anti-VEGF, and you should be aware of the adverse events such as an elevation of intraocular pressure and cataract formation in phakic patients. Combination therapy, the evidence is weak. Protocol U from the DCRNet showed that adding dexamethasone did not improve the visual acuity over ranibizumab monotherapy. And here is a chart showing precisely that, where you can see that the visual gains were pretty much similar between the two groups. So in summary, DME is a multifactorial chronic condition. If the patient shows vitreomacular traction syndrome, we entertain vitrectomy. For me, anti-VEGF is the first-line treatment. Multiple injections are required. Beware of switching, and chronic cases don't respond as well to anti-VEGF. And remember that steroids cause increased intraocular pressure and cataract. Thank you very much for your attention.
Thank you very much, Lite. Great presentation. Thank you. So my question is, if you have a patient with DME with history of either myocardial infarction or stroke in the last 3 months, could this be an impediment to treating these patients?
Well, you know, so it's not an impediment, but probably since you have other avenues of treatment, it probably would not be wise from a medical legal point of view. So I would probably hold off an anti-VEGF, explain to the patient that, and probably start with a steroid.
Okay, perfect. Thank you very much.
Thank you, Lite. Congratulations. So let's move to the next speaker. Next speaker will be Victor Gonzalez from McAllen, Texas, and he's going to present no responders and refractory diabetic macular edema. Victor, thank you very much for joining us.
Thank you very much, and thank you for inviting me. Today, I'd like to talk to you about non-responders and if we can possibly classify these patients. And I think there are sufficient data in order for us to be able to consider this. These are my disclosures. I do consult and receive research support from some of the companies in the field. Now, what is the basic problem? The basic problem is, as Lita mentioned, quite often, even after intensive monthly treatments with anti-VEGFs, there are, even in our major studies, patients who have persistent macular edema. And you can see here, looking at protocol I, 40% of the patients had persistent macular edema in a very rigorous, controlled study, 32% of them with reduction. And as was pointed out with protocol T, depending on the agent we were using, it ranged from 32% to 66% of the patients with persistent edema. Now, why is this important? Well, I think, looking at protocol T, a couple of things that we need to remember. Let's look at the studies and let's compare to see if there's something that we can come up with that may help guide us and help us determine when we can classify these patients as non-responders. Remember, protocol T has already been reviewed, looked at the 3 major drugs used in the country, very standard enrollment criteria. Visual acuities, as was mentioned, we stratified them 23/30 or better, or 23/30 or worse, or 23/20 or better. Center involved DME. No history of anti-VEGF therapy in the last 12 months, or any DME treatments in the past 4 months. And remember, this was a change in visual acuity at 1 year, adjusted for baseline visual acuity. And we've seen the robust gain in vision. But even in these patients, as we know, and Lita pointed out, at 24 weeks, we already see a 32% of the subjects in the aflibercept group having persistent edema, 65% in the bevacizumab arm, and 41% in these patients. And if you follow these patients out, as Lita pointed out, very early on, we could predict which patients were going to have this persistent edema long-term. Now, the conclusions were, as already reviewed, all 3 agents were very good in those subjects for which the DME had good visual acuity. When the initial visual acuity loss is mild, on average, these patients had very little difference as you follow them over time. And if the vision acuity was worse, as already pointed out, aflibercept tended to have the best results in this group of patients. Now, let's look at protocol I. As you recall, very similar, very robust monthly injections. Really, the important arms for us were the ranibizumab. And as you recall, it required either immediate laser or deferred laser for 24 months. And then in this trial, good visual acuity, center involved DME. The primary outcome here was a change in visual acuity from baseline to year 1. And again, we're familiar with the robust visual acuity gains in these patients at 1 year and forward. And even in this robust study, monthly injections almost on these patients, we had the same group of individuals that had persistent diabetic macular edema. So I think we can all conclude that we all are using anti-VEGFs as first line, but we all know and we agree that many of the patients do not have complete resolution in terms of either anatomical gains or functional gains in visual acuity. With this in mind, our group published in 2016 an ad hoc retrospective analysis of protocol I to see if we could identify, why and which patients were not responding and how early we may be able to classify these patients. The rationale, recall, anti-VEGF monotherapy, whether you combine it with laser or not, only 30 to 70% of those patients achieved a 10-line letter gain, 10 to 40% had a 15-letter gain. However, even with this intensive treatment schedule, monthly or near monthly application of the drugs, 35% of the patients failed to achieve a 10-letter gain or better, and 55% of them did not achieve a significant improvement after 2 years. So again, not all subjects are going to, and not all patients are going to respond satisfactorily to the anti-VEGFs. can we identify these unresponsive patients, and how early can we do that? We explored the relationship between early and long-term anatomic and visual acuity responses to anti-VEGF, and we wanted to see if there was an association with visual outcomes after 12 weeks of anti-VEGF therapy, which is basically 3 monthly injections, and visual acuity changes at year 1 and year 2. And when we stratified the subjects into those that gained less than 5 letters, 5 to 9, and 12, and then also when we looked at the anatomical correlate, those that did not have a 20% reduction in central subfield thickness, we found that in those subjects there was a limited visual improvement with anti-VEGF in the minority of the patients that did not have those clinically significant and meaningful improvements, both on vision and visual acuity. And outside a rigorous clinical trial like that one, maintenance of that intensive treatment schedule and monitoring required to achieve those gains is going to be a challenge. I can tell you the minority of my patients come back on a monthly basis. And this is just not practical in places like Latin America where we have limited access to these treatments. So what do we do with these patients? How do we define insufficient response? I think the data from that paper, has guided me in terms of how I use this data to classify and treat these patients. And it's simple for me. I stratify these patients. If they've gained less than 5 letters after 3 months, I'm worried. If they've had less than 20% reduction in central subfield thickness, I'm worried. I'm starting to look at whether or not I need to do something different. And this was observed in about 40% of the subjects in this trial. So here's the head-to-head analysis. If you're a WOW responder, chances are you're going to stay there, and at the end of 3 years, you're going to do very well. If you had intermediate response, some of them will improve, some of them will reduce. And if you had less than 5 letter gain and less than 20% improvement in central subfield thickness, then the odds, if you follow these patients, 3, 6, 9, 10, 12 injections, you're going to basically remain at the same level. So what happened to those subjects that had less than 5 visual acuity gains? As you can see, after 12 injections, even after 6 injections at 24 weeks, there's a very good prediction to what's going to happen to you at long term. And that is, you're not going to have, the minority can improve, but in a very artificial, very difficult way for us to treat these patients. We're not going to see these patients on a monthly basis and inject them on a monthly basis and follow them closely for 2 years. It's impossible. As you can see, even with that, over 50% of the patients had not had a meaningful gain in vision even after 3 years. So functional outcome and the predictability seems to exist somewhere between the 3 to 6 injections. And I agree with Lita. If I see a patient who's had no movement in visual acuity or anatomical changes, I'm getting worried, and I'm thinking that I need to potentially treat them. If there is some movement, I'll continue for the 6 injections, as was pointed out previously. Now, what happens to them if they have the anatomical changes? Again, if they have a nice anatomical change at the beginning, they're going to do very well. If they have a poor response, they continue to improve, but again, not to the level that we need to. So I think that we have the data in order for us to be able to look at these patients. I think, and I agree that, anti-VEGF is still the first-line therapy. I would give 3 to 6 injections. I will stratify the patient based on visual gains. If after 3 to 6 injections, I haven't had a visual gain, if I haven't used the Eylea, then I'll consider switching after 3 to Eylea and give myself another 3. If I've used Eylea, then I'm worried. If there hasn't been a significant improvement in visual acuity, greater than 5 letters, or if the anatomical change is less than 20%, I will consider looking at changing these subjects. Now, what to? Well, we haven't had the clinical data. I think you need to individualize that treatment. And as Lita did, steroids may be correct for some patients. I can tell you that I'm a principal investigator in the first study that's putting the steroids head-to-head with Eylea. And hopefully in the next 2 years, we'll be able to have data to help direct our treatment in these patients. For now, you have to individualize everybody's treatment. Thank you.
Thank you very much, Victor. One question, Victor. What is the role of the subliminal laser or the vitrectomy to treat these refractory patients?
Again,
in the real world. In the real
world, again, as Lita pointed out, we don't have good controlled studies to really help guide those. And unfortunately, as you know, those laser studies are going to be very difficult to be funded. But I think anecdotally, I've seen the Brazilian group have very good success with subvascular therapy. I'll be honest, I'll tell you that in some patients, I have added this myself and have had, again, uncontrolled, personalized benefits in some of these patients. But until we have large controlled clinical trials, it's very difficult for me to move you in that direction.
Okay, thank you. Thank you very much, Victor.
Perfect.
Thank you.
Yeah. Now I'm going to introduce to Dr. Jimena Mira from Mexico. Jimena is part of the board of the Retina Mexican Association, and her research field include multimodal imaging and vitreoretinal surgery. And today she's going to talk about the real-world treatment for proliferative diabetic retinopathy patients, laser, anti-VEGF, or combined therapy. Thank you, Jimena. Yeah. Are you ready? Jimena?
Thank you. Can you hear me?
Okay. Yeah, perfect.
Thank you, Andres. Thank you, Dr. Arturo, for this invitation. I'm very honored and pleased to be here today with you. Thank you very much. I'm going to talk about the real-world treatment for diabetic retinopathy in 10 minutes, so let's get started with all these topics. As we know, with increasing global incidence of diabetes in both developed and developing countries, diabetes has likewise increased in prevalence. Almost 486 million people worldwide are having diabetes, and 1/3 of them diagnosed with diabetic retinopathy and macular edema. It's very hard for the system health of different countries to consume the cost almost for 50% of it. And it's very sad that it affects our working adult population the most. So the first treatment for proliferative diabetic retinopathy is systemic management of diabetes. It consists of intensive medical control of blood pressure, blood lipids, and it's very interesting how a lot of trials and ophthalmology studies gave us a lot of information of it. One example is the diabetes clinical and complications trials, that what they showed us is that with an intensive insulin therapy on an average of 6.5 years, they won a reduction of 34 to 76% in the need of PRP. The same investigators or researchers extend this study in the next one called Epidemiology, Diabetic Intervention and Complication Study, having the same participants of the study, almost the same, quite 10 to 20 years after. And what they showed was the beneficial effects of extension and persist of additional risk reduction of eye complications. For 10 years, they showed us a 56% decreased risk of reduction in eye complications, and 23 years later, they showed us a 48% risk of reduction. This information can be very motivational for our patients, because if they know that, maybe they can have a better control and we can have better controlled eyes. Meanwhile, in the UK, they demonstrate that for every 1% decrease of hemoglobin A1C, they got 35% of reduction in risk of microvascular complications. So with these results, a sub-study of Protocol T did a correlation of vision acuity with hemoglobin A1C. And what they showed us is that with less hemoglobin A1C, more letters gained with different kind of anti-VEGFs. Second topic. Now, we're going to talk about the role of laser in proliferative diabetic retinopathy in the real world. As we know, PRP is the standard treatment for proliferative diabetic retinopathy. In the 70s, two studies, the DRS and ETDRS, told us all the benefits we got and the patients got for PRP treatment. A quarter of the physicians routinely use one sitting PRP with proliferative diabetic retinopathy, and the other physicians were afraid of doing that because of associated complications as macular edema. So what did happen was the Diabetic Retinopathy Clinical Research Network published the Protocol F. It's an observational study of the development of macular edema following pan-retinal photocoagulation given in one sitting versus 4 sitting. So in real world, many times we don't have that the precision that the patient will return, will have the money for next treatments. So what the results they gave us are the following. First of all, you should consider one PRP photocoagulation in one sitting with eyes without macular edema. It is safe. It increased patient convenience, decreased patient costs in travel and productivity, and there were little changes in visual acuity or edema. So even though if you give the laser or administer the laser in one sitting or 4 sittings, both are safe and clinical equivalent. But now we know that PRP was or is...
is administered directly into the eye.
Sorry about that. It's the anti-VEGF and PRP treatment for proliferative diabetic retinopathy. Let's see what, again, the DRC network showed us in Protocol S. Remember that Protocol S, there are several reports of Protocol S since 2015 until 2020. So I tried to summarize all those publications from 5 years in this one table. So what are we having here for anti-VEGF and PRP treatment for proliferative diabetic retinopathy treatment? First, anti-VEGF showed us 8 letters score in visual acuity improvement versus 3.6 letter scores in the PRP group. Same, 97% of the patients with anti-VEGF treatment had better visual acuity than 20/40. Both groups had peripheral sensitivity loss, but it was more in the PRP group. But interestingly, in the daily basis while driving, while doing our normal life, there were no peripheral loss perception. Both treatments needed retreatments. And interestingly too, in diabetic macular edema projecting for 2 years, it showed that 9% of the patients with anti-VEGF will develop macular edema and a 28% after PRP. In vitrectomy, the results were also favorable for anti-VEGF, giving us a 5% of surgeries versus a 17% for PRP. Also, for the severity scale for proliferative diabetic retinopathy, it was shown that with anti-VEGF, it decreases 2 or more steps. But with PRP, it was not accessible. Talking about endophthalmitis, there was just 1 case in anti-VEGF treatment. And to talk about costs, the Protocol S has 2 publications, but it's very difficult to have precise and true costs between only anti-VEGF or only PRP or combined treatment because all the environment that are around the patient. So, what about surgery for proliferative diabetic retinopathy? When to do it? When we have known clear in vitreous hemorrhages, when we have premacular hemorrhage, or macular involvement, tractional retina detachment. When we should do observation, when there is no macular involvement, and we have 15 to 25% of macular involvement in 2 years. it's very important that always we should do multimodal imaging before surgery, because we don't want any surprises in the macula or in the retina if we don't see very, very well all the studies before planning our surgery. Now, how to treat tractional retinal detachment? Before planning the surgery, we must see how active are the proliferation, the fibrovascular proliferations, if we can do some laser before surgery, or if we can inject anti-VEGF before surgery. Kind of couple of years ago with my mentor, Dr. Abel Ramirez, we made this study trying to have an exact day where we can inject the anti-VEGF and we have the better effect of it. What we found was that in the 4th day before surgery, it was the best day because we did a correlation between our histological findings and our clinical findings. In the histological findings, there were less endothelial cells. The lumen of the vessels were almost closed. They didn't disappear, but they were almost closed. And we take these to the OR, and what we found is that we get less time during surgery and also less bleeding. So, in conclusions, or in summary, our primary mode of systemic treatment should be pharmacotherapy with hypoglycemiants or insulin, and the primary mode of treatment for us as retina physicians for proliferative diabetic retinopathy is always consider conventional laser therapy and also anti-VEGF therapy alone or combined. We should always consider all the environment of our patients to take the better decision. Protocol F told us that PRP is not inferior or superior with 1 or 2 or 4 sittings, but we should always administer if we're considering in one sitting patients in PRP, the patients don't have macular edema. Protocol S, in their several publications, it's better that always we should take in consideration before starting a treatment to see if the patient is having macular edema present or not. And with this answer, in the 2 years, ranibizumab showed us that injecting the patients had better visual acuity, less visual field loss, fewer diabetic macular edema presentation, and less vitrectomy. So it's difficult to see all the costs around the treatment, but always, as I've mentioned, consider the whole environment of the patient. And for surgical treatment, it's very important that always we should use multimodal imaging to take the best planning for our surgery and also the treatment before doing it. It will be a better result if we should try before the anti-VEGF 4 days before vitrectomy or PRP for having best results. So thank you very much for your attention, and we're delightful to invite you next October to our annual Mexican Retina Reunion called Retina Cinco Continentes, or 5 continents. I hope we can see you, all of you, there. Thank you very much.
Thank you very much, Jime. Very good, very nice presentation. Thank you. So, brief question for you. In the real life, when do you think that is the most accurate indication for combined therapy, anti-VEGF plus laser, in this patient with proliferative diabetic retinopathy? What do you think?
I think that for combined therapy, there is always, we have to have the diagnosis of diabetic macular edema. We can start with anti-VEGF, and if we talk to the patient and if the patient wants to continue only with injection because all of the benefits that we saw in Protocol S, we can continue just injection, but maybe taking considerations of the whole environment of the patient, that if he can't afford, we can try both treatments. Start with anti-VEGF, treating macular edema, and then continue with PRP for treating the proliferative diabetic retinopathy.
Perfect. Thank you. Arturo?
So it's a great pleasure for me to present our last speaker in this module, Dr. Mauricio Maya. Mauricio is the current president of the Sociedad Brasileña de Retina y Vitrio. who is supporting this webinar. And Mauricio, it's always a pleasure to have you here. So go ahead.
So thanks, Arturo. It's an honor and a pleasure. Can you see my slides?
Yes.
Okay, it's an honor and a pleasure for the Brazilian Vitreoretinal Society to participate of these webinars, and congratulations for the organizers, especially you, Arturo, Tarek, Jorge Rocha, and also Andres. Here are my financial disclosures, and the background of these presentations is the DRVS and ETDRS gave us the classic indications of vitrectomy, which is no clearing vitreous hemorrhage for more than 1 to 6 months, and also the macular or impending macular traction and retinal traction detection. The rationale of posterior vitreous detachment, as you can see, is to eliminate the scaffold for proliferation of PDR, and in these cases, we will have a better prognosis. The surgical technique and instrumentation improvement gave us today shorter operating length, decreasing inflammation, lower incidence of iatrogenic breaks, expanding the indication, and with better prognosis, as you can see. And the main indication of the postponed vitrectomy are the classic indication, as you can see here, which we all know. However, we're now speaking about the early vitrectomy benefits, which is indicated for advanced and active extensive new vessels, for young type 1 diabetes with severe PDR, especially single eyes, and for DME, moderated vision loss, as well as vitreomacular traction. And here is an example. As you can see, we observed in this case a very interesting situation. In this case, we performed the posterior highlight detachment, as you can observe, using the transinolone, and we went to the periphery. We performed the vitreous base work, as you're going to observe, and after we did the conventional surgery, we just use again the transinolone, and with a ton of forceps, as you can see, there was a hyaloidoschisis in the retina, as you can see. So patients that are not going well with pharmacological treatment, they may have situations such as this, vitro macular traction, and in the end we do ILM peeling. And before surgery, we had a 2400 vision, and after surgery, we had here is 20/30 vision. So in cases that are not responders to pharmacological treatments, just think about subclinical traction that may occur in these eyes. The surgical techniques includes the preoperative bevacizumab and also the bimanual chandelier assisted technique, as you can see here. And in this case, I'm going to share with you, we perform the phacoemulsification, and after the phacoemulsification, it's very important to add the lens in the bag, as you can see here, and we go to the vitreous cavity and use the transinolone, and we induce the PVD, as you can see here. There it was a wise ring, and at the end of the surgical procedure, we just go and perform all the vitreous base work and laser, as you can see here, and in single eyes such as this, with a very simple surgery, we can do a very good job and avoid the situation of this patient to lose this eye as he did in the other eye. Another situation, as you can see here, is the early vitrectomy for diabetic macular edema, when the patient was previously submitted to surgery, as you can see here, and after that there was a cystoid macular edema, as you can observe. In these cases, sometimes it's very important to remove, especially in young patients that you had in the past during the first surgery, vitreous hemorrhage. It's important to remove the ILM with very gentle ILM peeling. And at the end of the surgical procedure, you just perform a fluid exchange, as you can see here, laser, and we can have, after the triamcinolone, very good results, as you can observe here, in before surgery 2800 vision in this eye. You can see it was a tractional retinal detachment due to a traction of the ILM, and in your right, after surgery, the vision of 2030. So this may also occur, no posterior hyaloid, however, ILM traction. And the preoperative bevacizumab is very useful. And when we have to do it, 3 to 5 days before the surgery, as our PACORDES group showed in a prospective study. And the benefits is that in the intraoperative surgery, we observe a reduced risk of bleeding, improved surgical visual field, and reduced use of endodiatrophy, as well as reduced ischemic neuropathy, as you can see here. Facilitate the removal of membranes and lower incidence of iatrogenic breaks and lower use of silicone oil. Okay, actually, there is reduction of vitreous hemorrhage, and the complications we can observe some tractional retinal detachment, but this is related to for almost less than 4% of these eyes. So it's a very interesting surgical technique. And we use in now patients nowadays. I'm going to share with you some cases. As you can see here, very intense hemorrhage. As you can see, we perform the surgery and we go to the vitreous base. And as you can see here, we use endodiatrophy, but not too much. It's very important to remove all the vitreous base to avoid traction of the anterior hyaloid and globe atrophy, as well as hypotony. And in the end of the surgery, we observe a situation like this. And in the single eye, we use silicone oil, which we believe is important in patients that have high risk of neovascular glaucoma. When we have to remove the silicone oil, so we do it 3 months after surgery, as you can see here, and we just remove the silicone oil in these eyes after the eye is not hot anymore, so we can go on and perform the removal of the silicone oil, and we may achieve good results doing this. Some patients, they have complications. As you can see here, in this patient, there was a residual vitreous in this first surgery. It seems it was a first surgery, but this is the second surgery. Take a look. A lot of vitreous here, a lot of vitreous in the base. We took a look if there was not vitreous in the posterior pole, but there was not a vitreous. But in the vitreous base, there was a lot of vitreous. So this was the scaffold for proliferation and for neovascular glaucoma. This patient had also Ahmed valve. However, we have to perform endolaser and also at the end of the surgical procedure to inject the anti-VEGF in these eyes, and this may solve the problem of these patients. Finally, another complication, which is patients that have surgery and lots of laser in the first surgery. So we go, this was referred to us, we go and we perform the phacoemulsification, we put in the bag, and as you can see, there are a lot of vitreous, very important laser, and these resulted in traction. And as you can see in the macula, there was a retinal folds. So we have to perform ILM peeling. In this eye, we just perform subretinal blab of BSS, and after that, fluid air exchange. And we had a good result at the end of the surgery with the resolution of the problem and improve of vision in this eye. So my take-home messages for you is that early perisplanal vitrectomy decrease the risks of future complication in specific eyes, and the preoperative bevacizumab 3 to 5 days before surgery using 1.25 milligrams is very important, reducing intraoperative bleeding, and is very helpful to facilitate the vitrectomy. So thanks a lot for your attention.
Thank you, Mau. Excellent, Mauricio. Thank you very much. Beautiful videos. So I have a question. Are you using any intravitreal injection, anti-VEGF or dexamethasone at the end of the surgery?
Yes, actually, at the end of this, before surgery, all cases, okay? At the end of the surgery in single eyes in patients that we observe new vessels or in some situations that was not able to perform a near complete vitreous-based removal, and there is also neovascular glaucoma in the other eye, I just inject the anti-VEGF at the end of the surgery, okay? In patients that are performed the surgery because of there's some traction and there is diabetic macular edema, I perform the steroids at the end of the surgery.
Oh, great. Thank you. Thank you very much.
Thank you very much, Mauricio. So we are finishing on time this module also, Andres. So congratulations for your coordination.
Thank you.
So let's move to the surgical modules. So Mariana is going to start with this third part of the webinar. Mariana.
Yes, I'm here.
It's your module. So go ahead.
Okay. Thanks everyone for joining in to this macular surgery module. We are going to have 14 retina experts sharing their tips and tricks in macular surgery. I have the honor to module this section together with Barbara Parolini from Italy.
Hi.
Barbara, are you there? Hi.
Yes. Hello. It's a real pleasure to be here with all of you. Thank you.
Thank you, Barbara, for being with us. It's a pleasure to have you here with all of us.
Thank you. Thank you.
So we have a challenging task that we shall start. What do you think, Barbara?
Yes. So let's move to the first subject. It is my pleasure and honor to present the first speaker, Dr. Virgilio Morales Canton. Virgilio, where are you? He will present.
I'm here. Do you see me?
All right.
Yeah.
How are you, Barbara?
Welcome, welcome. Fine.
Thank you very much for the invitation and the organizers. So you tell me.
We are looking forward to see your video on autologous retina transplant for macular hole, and the video will be discussed by our colleagues Tamer Mahmoud. I can't see Tamer. Where is he?
I'm here.
Hello.
Hi.
Good to see you, the big expert on autologous transplant in retina transplant in macular hole. So we're looking forward to see the video and to hear your discussion. All right.
Right. Do you see my screen over there?
Yeah. Yes.
Perfect.
Let me. It's good, no?
Yes.
Yes. Okay. Perfect.
So thank you very much for the invitation and being with colleagues from around the world. It's always a great honor. It's a new challenge to be in webinars quite often, fortunately, because it's part of the mental therapeutic that we need. And someday I hope I can stop the webinars and we can be together in a real Congress. I'm looking for that. So, but in the meantime, it's a great thing to be here, and especially for me today. I want to thank Mariana that asked me to present a video of this technique. That obviously Tamer, it's the one that is the chief of the technique, and I feel fortunate that Tamer has been my coach, my direct coach with this technique. The first time that I did it, I emailed him, and I'm sure that he remembers, and he answered me like a WhatsApp message giving me the tips. So during all this time, I've done some mistakes and some things that are maybe different from the rest of the world. So I will present one video. That is, this is the case. It's a 60-year-old male with 4 months of decreased visual acuity, 2800, no previous surgery. The lens was clear, and this is important for me because considering that it's a 65-year-old, I didn't try to do a phaco at the same time, but we can discuss that. In this case, it was a particular interest that there was in live surgery during the meeting in retina. So I was brave enough to do this technique. Brave for me, I don't know, and we'll see the video. So maybe I will stop. It was a large hole. It was almost 900 microns. So a regular macular hole. I did the separation of the hyaloid. I want to stop here because in this time I consider peeling the ILM, and it's something that Tamer, I would love to hear his comments now. Now I'm not doing this because Tamer said that it was not a bright idea. But anyway, I tried to do the ILM using Brilliant Blue, which I think from Dork, it's a great tool for staining. And I'm peeling the ILM conventionally. And here I'm doing the cauterization. It's something that maybe I can stop. I do always, in this technique, I like to do that because especially I don't like to have bleeding in the area that I'm cutting. So here I continue, and this is another thing. It's important not to cut, as I did in this case, as you saw. I cut it just at the edge of the area where it's cauterized. So it's not good. It's better to have a clear cut without touching any part of the cauterized area. This was my mistake, and I want to stop here also because if you see the area or the size of the heavy liquids, it's not large enough. So I'm just at the edge of the heavy liquid bubble, which is not good. And you will see what happens because here and this is another error that I did in this surgery. With the forceps, I used a max grip forceps, which, as we know, the plates are large enough, and I think this is why the thing will happen. So you will see the mistake here, and the max grip, I was not able to release the graft. It was stick to one of the plates, and with the endoluminator, even that I was using a chandelier, I tried to remove it, always thinking that you need to be very, very close or touching the retina, because if you are in the middle of the